So where are we going with the management of non-muscle invasive bladder cancer in the next 5 years? First of all, we have to ask ourselves where we are now and where are the issues. One issue is incomplete staging. Patients with T1 disease, so disease invading that first layer of the bladder wall, are often understaged. We have incomplete resections when we do the transurethral resection. And we are doing repeat resections. We're giving single dose of chemotherapy really just to overcome our own incomplete resections. We're doing frequent cystoscopies to monitor for recurrence because we don't have adequate tests, adequate urine tests to avoid those cystoscopies. We have relatively ineffective intravesical therapies, including BCG and chemotherapy, with lots of patients having recurrences despite best treatment. And overall, we have a very high recurrence rate, and we're always concerned about progression. So where are we going to address some of these issues? Better staging certainly is on the horizon, especially with MR imaging, although it requires more study before we can really implement it clinically. We've heard today from Dr. Kassouf about different cystoscopy techniques, including blue light cystoscopy. I'm going to talk just briefly about en-bloc resection, where the whole tumor is removed as one piece. Better urine assays. Dr. Zlata has talked about some of the need here for better tests, and I'm sure we will have tests in the near future. I'm going to talk mostly about better intravesical therapies. There's lots of activity going on here in clinical trials, lots of new drug development. So first of all, to en-bloc resection, what we do currently is that we carve off the tumor in pieces, and we have pieces of tumor floating in the bladder, and we then remove them. This poses a risk of tumor seeding other parts of the bladder, and it makes a lot more sense to actually remove the tumor in one piece, where we outline it with a laser, for example, or with electrocautery, and then we undermine it and we take it off in one piece. And we give it to the pathologist as one tumor so the pathologist can give us better assessment of exactly what's going on. There are several advantages to this technique, which is becoming more popular. When we're thinking about new drugs for non-muscle invasive bladder cancer, we need to be thinking about disease states. And this is a complicated slide, but the whole idea is that we need, as physicians, we need to place patients in the proper disease state and decide what is the best next step for them, whether it's their first tumor, their second tumor, their third tumor, whether it's a high risk or a low risk tumor. Each patient has defined criteria that will determine the next steps. In the context of these disease states, one of the new exciting drugs that has already entered clinical trials is a gene therapy with an agent called Instiladrin. This is actually put into the bladder as a virus. The virus is taken up by the cancer cells, and the cancer cells express interferon, and this leads to cancer cell death. There are two drugs that are sort of Trojan horses that enter bladder cancer cells and are only turned on in a cancer cell and not in a normal cell. This drug, BC819, is a ring of DNA that encodes for the diphtheria toxin, which is a bacterial toxin that kills cells, but it's only turned on by this H19 promoter, which is found in cancer cells only. The other Trojan horse that is currently in clinical trials is this agent, which is another bacterial toxin, a Pseudomonas toxin, linked to an antibody. The antibody recognizes cell surface markers on cancer cells, but not normal cells. The toxin is taken up and it kills the cancer cells. Again, this is a drug that's being put into the bladder in patients with BCG unresponsive disease currently. The immune checkpoint inhibitors are very exciting advances, and there are at least a couple of these drugs in clinical trials in BCG responsive disease, and likely to be other drugs in the very near future. Interesting here is that these drugs are given intravenously and not into the bladder, which is a new paradigm for bladder cancer treatment moving forward. And finally, another example, this is a Canadian drug. This is a sticky polymer that sticks to the bladder wall. It contains a chemotherapy drug, or it's loaded with a chemotherapy drug. The drug is then slowly released into the bladder wall, which overcomes one of the biggest limitations currently, which is that drugs are immediately washed out when a patient voids after treatment. So hopefully, in the next 5 to 10 years, we're going to be like the proverbial child in the candy shop, and we're going to have all sorts of choices to make for our patients with non-muscle invasive bladder cancer.